Okay, a copy of those pictures will be sent out to everyone. Thank you so much. And thanks for coming back quickly from the break. They have the word.
Yes. So a little wordsmithing was done to number 2. Maybe what you could do is put that in a clean view. So now it says to improve accountability of donor eligibility determinations made by responsible persons, examples given, medical director, trained non-physician designees. These determinations should be reviewed during inspections and audits. So FDA does inspections. Professional associations can do inspections. You can do self-audits, so that's why that's worded that way. And when non-compliance to FDA regulations are identified, they must be formally addressed. So that does allow, any entity to formally address it, including FDA. So does that capture the
You could
discussion?
put or else at the end. No, I'm just kidding. I'm just kidding. I'm just kidding.
Or else.
I couldn't hold back. Sorry.
Well, if you want to put that in there, sure.
So when these are sent up to the BOTSEC and then the ASH does it, refers these to the agencies, I guess. So what's going to happen with this one? Who's going to own it? FDA.
Do you want us to still identify who does the inspections and who does the audits?
I don't know. I'm just kind of wondering how this would.
We could add the parenthetical phrase again, for each of for inspections and for audits, and that'll make it clear.
Yeah.
I guess it would be FDA. I mean, AOPO does audits or inspections too. FDA and professional societies, I don't know. Accrediting body. How about accrediting bodies? FDA, comma, by FDA, and then FDA, comma, accrediting bodies. I mean, ATB calls themselves an accrediting body, and they are. Audits, I guess, would be establishments. Does that read okay?
My question is, again, during an FDA inspection, will they I'm rethinking what Anne said earlier. So if they go against their SOPs, the FDA can call it out. But if it's a medical director scope of practice that has led to a problem, that's something FDA can't touch.
Well, we're looking for non-compliance to the regulations.
Okay, yeah, this is fine then for me.
I mean, that SOP, not following your SOPs was just an example. Okay, I think we can move to number 3, and then we can wordsmith that one and then vote and move on to work group 3 and 4. This is to address the lack of information about how many donors there are, across the board for all HCTP donor types, and also use, distribution.
So, we already do something similar to this in blood. CDC and OASH in collaboration with NBCUS. I mean, this is something that we've talked about doing for tissues. So just I'd mentioned this yesterday as well.
Are you suggesting that CDC can help with this?
I think so. I think CDC and OASH, if Jim's okay being volunteer, we could do that.
If my boss concurs.
Yeah.
Is there funding for this?
No, I mean, so, the NBCUS is, yeah, no, I mean, we'd have to talk to Jim about that. Jim, I mean, it's not. So what happens is the NBCUS, we don't contract it out, so it's actually administered by CDC.
For those outside our world, NBCUS is National Blood Collection Utilization Survey, done every
Every other year. So, I think we would have capacity to do this issue. I guess we'd have to talk, Jim, I guess.
So it must be funded and periodically collected, analyzed and published.
We could take out NBCUS, just say see.
Yeah, that's just an example. And
Yeah, I think that funding part is very important because that's why this hasn't been done yet. Let's be honest. It hasn't been done yet because nobody's ponied up money. And
well,
and the government pays for this in other realms, but not in tissue. And
Yeah,
we're
no.
trying to work on that.
Trust was funded by the government. It was a contract,
Yeah, and the last one was in 2050.
right? So that was
Yeah.
supposed to happen
Well-
every 2 years. That was the plan, and it didn't.
Yeah, so I'm saying that the funding aspect needs to come along with that. So I'm just saying that that's great that that's added.
Can I also add something that's not up there that might give some more teeth? How about risk assessment? We should tie this into, we don't know what the risks are. And this is to give us the foundation of that, right? I mean, we don't know what the denominator is. We don't know. I mean, so I know that takes it a little bit away from utilization or understanding of availability but I just feel like it says donor testing outcome, which leads you into feeling like we're going to understand risk a little bit.
Would that be taken up in part 4 with biovigilance?
But it could be tied together, right? I mean, we should link it together. That way it doesn't look like it's standing by itself, like we just want to know the numbers because we want to know the numbers because we don't know the numbers. But really, we need to know them because it does give us an assessment of what the risk is for each tissue or when we have problems.
Yeah, it covers donor screening and donor testing information, to analyze.
Thing is that it should have some reason why you want it maybe in there, not just that we're collecting it so we don't have it currently. It just connects the dot. And maybe if the other recommendation sat underneath it, it'd be fine, but by itself, it looks like we're just looking to, get a bunch of information, which we need, but we should tell them why we need it.
Are we in a postprandial low or is everyone happy with this as is? So people are happy with it. Well, I'm not gonna look a gift horse in the mouth. Shall we vote then on these 3 recommendations? Sorry, Diane. Okay. Okay, we'll do it as we did before. And is everyone online back from their lunch break as well? Yeah, okay,
Yeah.
great. So with a show of hands, please tell me if you agree with recommendation number 1 for working group 2 as is written. And online? Please come on camera. Or show your reactions. Okay. Et voila. Okay, thank you. I think it's passed. With unanimous assent. Anyone against? Okay. Recommendation number 2 for working group 2, as is written. All raise hands who are in agreement. Anyone against? Okay, I think we've passed with universal agreement. Ah, there is one.
No, I voted no.
You voted no, Lou? Okay,
Yep, voted no.
please let the record show. There is one against. And for recommendation number 3, to inform national standards of, well, I don't have to read it, as is written. All who agree, raise hands. Anyone against? Okay, congratulations again. Lou, we can discuss further, but at another time, I think.
Yeah, no need to beat that dog again.
Okay. Let's move on to number 3, working group number 3.
Okay, so this group is, work group 3 was to look at tissue as it leaves the processor and goes to the consignee. And this is where current regulations continue to apply because it's very clear that the FDA has established requirements to deal with it. And in order to do this one, we got together the people who, both the processors and the people who manage the, who receive it at the other end, and particularly the large healthcare system. And what was really apparent is that there are a lot of people who touch tissue in between leaving the door and getting somewhere else. There are group contractors who buy and sell and ship. And I think that was manifest in Kristen's presentation yesterday, that it came in a big box, and inside the big box were little boxes with other products. And that the integrity of the box was one thing, and that was what the shipper was dealing with, making sure that it went to the right place. But then once it got to the place, it opened up and there were lots of products inside. And so we didn't know how to deal with that particularly, because there is no clear-cut regulation as to how and what goes on. It also doesn't appear that there's a lot of problem in that, in that what we don't know is how many times it gets violated, gets lost. It's not tracked, but it doesn't show up in adverse outcomes. So we decided pretty much to leave that one alone. But this is sort of the scope of the issue, is going from point A to point B, and after processing, but before use, but into the healthcare system. So our recommendations are as follows. The first one is about improving the capabilities and effectiveness of electronic systems that the healthcare software companies provide for tracking tissue products. Software standards setting organizations, and they should identify and finalize critical data elements that must be included to support tissue biovigilance. Software must be capable of electronic exchange with the EMRs. Now, that makes lots of sense. Most of the electronic healthcare records that we have today are charge capture systems. And we had Epic on this group, and Epic was really clear. And we asked them specifically, is there a biovigilance package which goes into the EMR? And they said we could build one, but no, it's not, nobody has ever asked for it. And so I think it's this group's, and that's the language, and we can look at the other one that we moved down from above, which is to optimize cell and tissue product traceability from donor recipient back to the donor to the use of electronic systems. They must be required by health authorities, electronic medical records, and they have functionality to accommodate a variety of long distinct ID codes assigned to products manufacturers' requests for product disposition from the end users should be required. I mean, so they're very similar type of things to talk about. They're a little bit different, but the premise is as to how to do it. The reality is that the way that tissue is managed once it gets to a hospital is that it is not uniform, that we enter, and I don't know how many of you guys have worked with tissue processing. We use a separate software system at the university, and it's run through the operating room. We don't have a centralized approach. We have the blood over in one side, we have tissue in another, we have ocular tissue in a third silo, and it's not homogenized at all. But the ones that go into the OR related tissue stuff is put into this facility called TrackCore. And inside of that, some of the codes that are on the tissue samples can be scanned in, which may or may not include it'll certainly include the lot number out of which it came, and it may include a specific serial number for an individual product. There is no place in there for the unique donor identifier. That has to get linked back into the processor side as to where things. But the long and short is that only some of the codes are used from the tissue processors. Some of them have to be manually entered. Some of them are electronically entered. They end up with different elements associated with what is available on the labels which are there. And there's a huge heterogeneity of information provided to the end user, which it's compliant with FDA regulations, but which comes in a format which lends itself to error. That's why we put this language in as it is, but we needed to get the sense that we are trying to look at this in a function which is not just inventory management, but also will potentially aid in biovigilance related efforts. They're not built into the system today. A lot of the information is there, but it's buried in a place that is not readily retrievable. I don't know how many of you have tried to get into Epic and find stuff. Packages, it's gone.
So I think the word integrated is what we really need, integrated with the medical record, because yes, we used a freestanding system. Emory uses a freestanding system. It's not readily capable of going back and forth. There's a lot of manual entry. It takes a lot of coordination for all different kinds of tissue. So, I mean, I like the electronic exchange, but integration, interfacing, all of those kind of words would make it a lot more trackable, traceable. I don't know about Epic because they don't have a blood bank module. So everybody has to modify whatever they're doing to have an interface with that. So even though they have Beaker and they have all of that, whereas Cerner does have a laboratory, has the blood bank, SunQuest does. We modified SunQuest originally to take all of our tissues, and we put it in there and gave it our own codes and did everything so we could track, because it was too hard to use the codes that were on the products. But eventually we went to a freestanding system because there were just too many different types of tissues, and it was just much easier to bring it into that system. So, so forcing this is imperative if we really do want to go from vein to vein, and back.
It's Daniela. Can I answer that? When we think about back system, blood establishment systems, which we would need a TEX tissue establishment system. What bothers me is that I think we're still a little unsure about who's receiving, who's distributing. And that has to be corrected. And when we actually develop a BEX, we're keeping in mind who's actually touching the product, scanning the product, distributing the product. And I'm not sure that's worked through yet. So Dr. Pruitt, you mentioned this is scary. Maybe we should create a centralized system. Well, maybe we should consider that. And if you do, that's how you should approach developing a TEX.
The EMR came about because of a government mandate. I mean, they said you've got to move everything for a hospital systems into electronically interpretable information. It created a lot of problems. It created a lot of gaps. And I don't think, we're not here to fix the EMR. We're here to address one of the gaps which was created by the mandate that we use in. This is one of them, is that multiplicity of systems produces gaps. Unless we can figure out how to homogenize, make them interoperable or integrated or whatever phrase that we want to use. Huge effort inside of HHS. Been going on for how long? Long time. But we need to, this is an identification of an issue where we need, it is important that we figure out how to address the issues of biovigilance inside of our electronic medical records, as well as inventory management. Everything we do today is inventory management. And it's going to be charge capture, which is another big point of why we have electronic medical records. But there are other purposes that we can build into it. And to the end that we need to build in biovigilance packages into these healthcare related systems. I mean, the guys from Epic said, I mean, they can scan and put in GS1, they can scan and put in ISBT 128, they can scan and put in a whole bunch of codes. The question is, what are they going to do with them? And this is where we need perspective as to say, what do we want to do with these codes? And we've got a product coming out of a processor with a code on it. And we've got a consignee over here who's going to receive it. And we need to link them in terms of biovigilance processes. Was the temperature maintained? Was all the packages intact? As Kristen pointed out, one of the things came in, they didn't have it sealed on both sides. Was it opened in transit or not? Was it this? Who knows? I mean, there are lots of gaps in our biovigilance effort. If what this is about chain of custody, which that's my phrase that I like to put into this, it's not totally dissimilar to a chain of custody in criminal cases where you show that the thing which you're going to use as evidence at the end was not tampered with on its way through. And what you want to show with medical products of human origin, whether it's blood, whether it's tissue, whether it's organs, is that what you thought you got at the beginning is what you get at the end. And how much can it be tampered with on the way through, or not necessarily tampered by force, but by omission, by error, by break in process or techniques. There's a lot of breaks in logistics which occur. You can learn that through the operations committee of HRSA when we're just dealing with a couple thousand organs on how you break stuff, how things break down. Well, and in millions of products which come out for tissue, there are breaks in logistics, but we don't have any record or even notion as to where they go. And is it important? We don't think so, but we have nothing to prove it.
I wanted to ask a quick clarifying question. Was the intent of this work group to regulate a text system or a tissue establishment system as a medical device? I know that that's been a barrier to Epic and other EHRs to develop blood banking modules. I've heard from their industry because of the regulatory oversight involved. Or is the intent to build a similar system outside of those regulatory umbrellas?
The intent of this was just to look at the process and find the gaps. It was not it was not a regulatory element at all. The regulations are relatively sparse in this space, but we recognize that every tissue product that comes out of a processor has to go through this to get to where it's going to be used. So that is why we addressed it. And we looked at the available tools that we have today, which is mostly, at least in the big users, the hospitals. None of this stuff is addressed to how do the dentists get their tissue? How do the people who do outpatient wound clinics get their skin? We didn't even go into that but we did look at the space, which is in the big users like the hospitals and the spine surgeons and the big burn centers and stuff. That is the space that we looked at, recognizing full well that we did not capture everything.
Can I mention just the subject matter experts that were in this work group? It's in your report, but they included healthcare providers, the HCA Healthcare, Veterans Administration, and then representing healthcare software companies. It was Epic and Oracle Health. The standard setting organization was the Joint Commission, and then federal agency that provide health coverage, specifically CMS. So they were the subject matter experts that developed the recommendations.
Question for Tim and Cassandra. For your systems at your respective institutions, did they also serve as a primary inventory control database for your tissues?
You can go ahead first. Cassandra.
Yeah, I mean, at first, when we adapted the LIS system, that was the primary inventory, and then when we moved it over, it was the primary inventory also.
In our system, yeah, it's just in our system as well, we have separated the primary inventory control. Tissue used in the operating room is run by the operating room. Tissue, and particularly eye tissue, is run through the ophthalmology department and through the eye bank, which is affiliated with the university. And outpatient tissue and children's tissue is run in a different site. I've talked to Claudia about trying to consolidate things into a single entity, which would keep both good management structure and biovigilance efforts. And I think that, you know, it could easily be done through blood, but it would need an expanded mandate from the system.
With your current operations, is it a manual process to take it out of the inventory? Excuse me, and then assign it to the patient's medical record, electronic medical record?
It's hit or miss. Some of them are directly translatable and some of them are not. It's not that everything can be scanned.
Same thing here. I mean, a lot of it could be. There were ways to transfer it once you allocated it to a patient, but it's not 100%.
Thank you.
I've been wondering about the sentence, finalize critical data elements that must be included. Who is going to decide what those elements are?
Right.
Basically,
Right.
it's going to decide.
Thank you.
It will not be deciding, no.
Thank you for
But it
volunteering.
goes to the point of what you're describing. I think the A, as it was written here, is prescriptive. And that's good, because it says you must use these kinds of systems. What I'm wondering about is there anything that's stopping anyone from doing this? From putting an electronic software management system today, a company that would create, and you mentioned one that's out there. So they're not doing it. So why are they not doing it?
Because it's not cost effective. Biovigilance is not a revenue center. Inventory management is critical, charge capture is critical, but biovigilance is not. And that is where we actually do need government to describe issues associated with what's important for human health and to come up with strategies to not break the system at all, but to enhance the benefit for the people who are getting the products. Because right now it doesn't generate revenue.
I think that's the key part, because we could make all kinds of recommendations for could be doing, but it's not going to happen unless there's a mechanism and a driver by which that's going to be.
Correct. I mean, if in my mind, the charge stuff is, I don't know if Diane's still here, but I mean, the way that things go is either it becomes part of a condition of participation for getting CMS accreditation, or whether, you know, you can get the hospital associations to say, look, we have a responsibility to the people who sit in our hospitals, so we need to figure out how to do this better. And again, to do sort of like we're talking about with the AATB, is to set up standards and guidelines to say, this is what we need to do. And then by God, somebody's going to have to convince Epic that there's maybe some impetus to do this. But right now, if they don't have, they will just charge an arm and a leg in order to come up with new packages. Yeah. So we have to actually describe what we want.
I was actually wondering, is this someplace where CMS would have thoughts on this could be required by CMS?
Well, I guess our concern would be requiring an electronic system could. However, I didn't bring this up yesterday when I talked about, our COPs, but one of the things we have done, is if it's something that you think is going to take a lot of work, it's going to take time. One of the things we have done is we had at least one rule where the effective date was one thing, but we also had implementation. For instance, in 2016, I was on a long-term care rule, and certain requirements were, the provider was expected to be in compliance as of the effective date. Then we also had certain requirements that they were effective, but the provider was not held accountable for, say, 1 year or 2 years. So something that, especially that might be considered burdensome, have a mechanism that we can kind of give them to comply with. And we have done that at least one rule. So that would be our concern. Requiring any specific electronic systems would, there could be a way around. Was that?
Yeah, so are there actually any hospitals that don't use electronic systems now that you're aware of?
I'm not absolutely sure. I don't know. I know that there's varying degrees. Some may be very, you may have large teaching hospitals that virtually everything's electronic. May have small rural hospitals that may be on certain things.
I do think that we need to remember here when we say healthcare software companies, the majority of our tissues may be going to dental offices and not to hospitals that have good Epic systems or something too. So it may need to be general enough that the end user needs to have an electronic system to handle the tracking, but I don't think specifically stating something is going to help all of the small offices or surgery centers, dental, ophthalmic, things like that.
Didn't Diane, you mentioned a couple of, what are they called, AHCs or the ambulatory centers, and the way CMS defines them? Ambulatory surgical centers and the CAS and the hospitals. The CAS, yeah. So maybe when we write it, we should write those particular things, not just the hospital, because that's where, I don't know, those are some where dental offices would be, or. Well, we do not regulate dental offices at all. So there's no.
Right. I mean, that's just part of the national problem, but we have to recognize that we should need to address the things we can address.
Okay, but we can write in the ambulatory
Right,
centers.
we can put it in an ad, and just say up front that we recognize this does not encompass all the issues.
Right.
I mean, there's a lot of private physician offices and dental offices which use human tissue. There's a lot of small clinics which use human tissue.
Mm-hmm.
But to capture most of it, we want to see.
And call out all the names of the CMS, like locations that there could possibly be. I was just trying to be as inclusive as possible for the things that we do have.
Dr. Pruitt, in blood center world, we provide the BECs to the hospitals. And that's that two-way conversation that happens. We're implementing pre-hospital transfusion. We provide the BECs to the ambulance services. Who provides or who would be providing the BECs? So who would be the supplier of the BECs in this model?
In theory, the information which would come from the processor, because that's the input portion of how the information gets to the hospital.
Mm-hmm.
But to the end that the hospital, I mean, this is a little bit like phone tag, because the OPO, or the initial donation related, safety related and demographic related information, processor, who also has to have it. I mean, but it gets edited on the way down. And so that it's edited for purpose. It comes from the processor to the facility.
So
But
the
a
OPM.
hospital may get tissue from 4 different processors.
Okay.
More than that.
I mean,
What
I
we
was
get
just
tissues
making it
from-
up, medical device company compared, and also from a direct tissue processor. Their burn center may get skin from a different place. So really, is it the end user that we're trying to talk about here, that all end users must have a system in place for electronic tracking and trace?
I mean, I can't remember when I asked how many different processors we received tissues from. 25. It's a lot, and and everyone has their own different coding and lot numbers and everything else. And well, they have to have separate, but they have different coding components. And some of it is enterable into the system and some of it isn't.
And so in your ideal system, if I gave you a magic wand, who would you like to be the owner of the system, and how should it be distributed?
I think what we're trying to get to is this is one of our big gaps in the way we work today. And what you would really want is seamless information from beginning to end and then back again if there's anything that comes up. We just have to figure out how to get around our current problem. And I don't know what is the least disruptive, most effective way to go. But that's what I would like us to do, is to maximize benefit for the end recipient, which is the person who gets the tissue, without breaking the system in between, which is going to hurt more people. And so it's a matter of saying, what is our goal and how do we do it? And what we need to do is to figure out how do we put accountability in the system to do what we want to do. We can do it with money. I mean, we can buy our way out of this, but I don't think anybody's going to pay for it because it doesn't.
Could we switch to track changes, please? For the typing, thank you.
There any, yeah.
Susan, then Stacy. Yeah, sorry, I think that something that says we'd like software to be developed is aspiration, but let's be honest, software won't be developed unless there are buyers who are willing to pay for it. There won't be facilities willing to pay for it unless there's a requirement for them to implement it. So my proposal is that our recommendation be a requirement that facilities that implant tissue must have systems to enable trade prior to the recipient and recipient to the supplier. Now we just heard from Diane that maybe we can't require an electronic system, and maybe, the wording may have to be that they have to have systems in place. But I think what we need is a federal requirement for those facilities that are over which CMS has some authority. And then if they have to have those systems, they will.
Yeah, we haven't gotten to 2 and 3 yet, but there's a rewrite of number 2 from CMS, and we'll get to that soon, and it does address that, I think.
Add to what Susan is saying, I wonder if the second part of this is I'm going, Dr. Pruitt, to what you said, is that some of the tissues we get, we can enter that information in our systems, and some of them, they're not labeled in a manner that we can enter that information. And it seems to me, it doesn't matter how great your computer system is, if the product you receive doesn't have a machine readable label, it's really not going to deal with that. And so do we have to put that here? Is that something that's covered in the good tissue standards?
Selling electronic.
The sound is dropped off.
the software standard setting organization should also do something. At the other ACBTSA meeting, we had a presentation from a gentleman who represented that group that's looking at setting up standards for software, right? For electronic health records. I think that's what he was doing. So it's directed at two entities, not actually the end user facilities. That comes next.
This is the middleman approach. And this is the logistics of getting from processor to that. And to Susan's point, I would state that going from the processor, what we want from in human tissues is traceability back to the donor. Unlike a device which is manufactured inside of a facility, these are non-manufactured products in the sense that they come from somewhere else. And that is part of the regulation now, is that it's not only traceable back to the facility and the processor, but back to the specific donor. And that I think is a critical difference, because when we get to the informed consent part, which is going to be later, those elements are really critical. Is that the unique components of the fact that risk is associated with individuals rather than manufacturing related issues, although there are manufacturing related.
If I could, because I see edits being made, I think that last sentence there that's been added, it's not necessary because that's covered in number 2. I mean, we talked about it already, but we haven't gotten to 2 yet, and it's actually it's more specific there. And even the rewrite in 2A is more specific to the end users. But the software development companies and the standard setting software for software entities, that's who number 1 is directed at, that they need to do those things.
And they need guidance from the oversight folks who are actually looking for not just revenue savings for healthcare systems, but for the benefit of the recipients who come through. And that's actually the role of government in this system, is to say, look, you need other things built into it. And like Epic said, we would build it if they'd ask for it. But if it's only built for revenue capture and inventory management, that's not sufficient to do some of the biovigilance efforts that we need to have happen.
Ray,
Do we need EGs here or IEs to identify what I was just talking about, healthcare software companies and then software standard setting organizations? Do we need acronyms here?
Ray, then Cassandra.
Yeah, also,
Oh, wait,
I-
Ray first.
oh, I'm so sorry. Go ahead.
Okay. I was going to say, so I work for a software company. I don't, but pretend that I did. Sell me that pen. Why should I do this? Is there a mechanism that it could be encouraged? Like, for example, is a recommendation to say, establish a funded program where you could put out through some agency, put out an RFP, which indicates what kind of characteristics you want in a software system, and look for responders or people to come in and submit that to build a system, which then, as you describe here, can be recommended as a requirement for organizations to implement. But I'm wondering on the software company side, what is the incentive for them to do this? Because I completely agree, there's not an economic one to do it, which is probably why it hasn't happened today. So could government or an agency support this by making a recommendation that you establish some kind of mechanism by which you could put out an RFP, get proposers to come in and propose to meet the criteria, the requirements that you list as being important for this electronic system to have?
I think along those same lines, I think we're spending a lot of time pushing on the electronic medical record people. But the people who have developed these freestanding tissue programs, and why we went to it, they're getting paid a lot of money. I mean, those are expensive programs. And I don't know who they are, but I don't know whether they work with the tissue banks. They surely are not working with the hospitals. It's freestanding, obviously. So why are we pushing so hard on the electronic medical record side and not pushing hard on the tissue bank side? for that type of interface between the two. Because I don't think the burden is completely on the hospitals to figure out, yeah, there needs to be mapping, so that can be biovigilance wise in the recipient. But there is definitely a component of all of those tissues and their names pop up and these little, it's all nice and wonderful. So somebody spent an awful lot of money and time making that part of it work. Who's investing in that part? And can there be something written to that effect of how there needs to be working together with the, instead of it all being the recipient now, because we're on the recipient side and we're in the hospital. I think some of the burden should be written about what the tissue bank should be. Well, yeah, I think they need to work with the electronic medical record systems that are there to build an interface for tissue biovigilance. So, because you're saying we should define what it is we're trying to access from them, but we can define all we want on the recipient side. If the barcoding or the information is not embedded in the labeling of what those tissues are, how are we supposed to extract that? How are we going to get that information? And so I think it's a big ask, and one that is not going to get done and driven because it's not money making. But hospitals are still going to go buy this, system to manage the inventory, which doesn't help us. What we need is hospitals to understand that this is part of taking care of the patient, but the tissue banks need to comply. And I don't know how to make them comply. I don't know whether we go back to where we were, because CMS isn't going to be regulating in that area. We were just talking, Tim and I, about labeling, which we didn't really talk about, which is a big part of this. And that goes back to FDA. It doesn't belong in the recipient side. It belongs in what about the product? And that, what's in the barcode of the product is just like the ABO and all the other things that are in the blood product labeling. There's mandates of what should be in there. So it can't be that the hospital is deciding what is going to be.
Remember that 361 HCTPs are not licensed products, so there's some limitations to that.
I get that, but I'm just saying that this is a big component of our problem. And we can't have the hospitals thinking they're just going to be able to fix this on their side. It's a two-sided problem. And I've been on the hospital side. It is not easy to do all of this and keep it going. So and we had a hospital that was willing to try. We had a tissue coordinator, we had all the pieces, but it is onerous beyond onerous because it doesn't tie into the patient.
So, I mean, if that's being added, my question about should we have some acronyms for healthcare software companies in parentheses right after that at the first sentence. And then the standards, the software standards setting organization, the gentleman that presented to the advisory committee. Oh gosh, when was it? Back in 2023, Albert Taylor. He was a senior medical informatics officer, standards division, Office of Technology, Office of the National Coordinator for Health IT, U.S. Department of HHS. I mean, is that that who we want to identify there? That they're the software standard setting group. He spoke to USCDI and ONC Health IT certification program. So that's what that's linked to, though, is acronyms. Yeah, ONC Health IT certification. I don't know. Yeah, it was about HL7. That might work, I think. But the healthcare software companies, ones that were represented were who again? Epic.
Epic and Oracle were the main two who were there, but the number of people who are in healthcare software or the subspecialty components for either blood components, histotrack. I mean, even our little groups that we do, there are at least 5 or 6 which are outside of Epic, which then have to integrate in and download material and put it in a useful way that anybody can retrieve it. It's great for charge capture. It's impossible for healthcare use. This, which is about trying to make sure that the person who needs the tissue gets the tissue, they get the right tissue. We need to make sure it's functional to the extent that it works.
Including the implantability part, right? Because that's the part we
We'll
want to
get
turn
there.
back around, right?
But we're going to get to that.
Yeah, put maybe Oracle Health as well, if you want to.
Yeah.
Okay, thank you.
We need anything out of the second previous work group, the optimized cell. The question regarding product disposition information is for use or non-use. I think that is critical. Right now, the question should be, should it go in this section or in the next section, which is in the knowing what happens to tissue. I think, we do this, we have to do it in organs, as you heard about all the stuff about those little vessels, when the organs that we don't transplant, that we retrieve. Yeah, all of that stuff is known. The fact that it's not required here on the tissue side, it may not be as critical in this sort of thing, but certainly, I don't want to say this, but there are elements of what you have when somebody goes through the effort of donation, that we have an obligation as a system to respect the act of donation. I would say that we should probably ensure that we know what happens to human tissue.
I think the disposition is critical because of the infectious risk too.
You're
for how
saying
long
the final distribution,
dis-
whether disposition, whether or not transplanted, if so, where, who,
Right.
or discarded.
discarded, and if discarded is like because it expired
Right.
or discarded because it hit
Of
the
a-
floor and
of an
could be-
error,
Yeah.
yeah.
Yeah, I
So
mean, I think that people or organizations that receive these products should be obligated to document that, right? And
we
have
do it for blood.
have it very readily available. And I think one of the things that actually surprised me about all of this was that that's actually not the case. That's a really big departure from blood.
They are required by Joint Commission and everything too, also to track it in, track it through the system, track it through distribution, keep the ending result. But that's only one organization,
But it's a major one, and all the temp and all.
And as they said, they can't
They
find it.
can't cite them for non-compliance to their own
I mean,
standards because
this
it's not
should be
required.
I think, a governmental requirement. That would be my take.
That makes it CMS, right? Or does that make it, I don't know, whose jurisdiction
Yeah,
is it under?
Diane would have to.
If it's one of the organizations that we regulate, then it,
Yeah, if it's CMS,
have
it's
to be
only
written down.
goes so far. If you're trying to
Right.
track everything through the dental office, through the other offices,
I don't know, because I'm a dentist, but who do they have to answer to? Don't they have people they answer to?
Some states, it's in the gap analysis that some states may have oversight of dental offices.
But that might be the only place. I mean,
That's all that was mentioned.
It's just part of the gap. And what we're going to try to do here is make perfection not the enemy of good.
right?
We need to get what we can do
Absolutely.
and do that.
I think if
and-
we start with Exactly, Tim. I think if we start with the people that CMS does regulate.
Right.
We're taking away a lot of the risk.
Yeah, because other people will start to fall in line when we, as a system, change a culture to think that this is important. And so as long as it's never in anybody's radar, then we're a little bit lost. So I would say let's work on what we can work on and see where we can go. I would suggest that we move that last sentence up to the first one, and then we'll eventually get rid of that second bullet underneath. Just have one recommendation.
But then this second section here that says that an end user should be required.
Yeah. I think it needs to be, I like the idea of leaving it not defined by CMS, but the answer is if it is going to be required, it can only be required for entities which are overseen by a specific agency. So the answer would be yes in practice, but leave it open for other people who aren't overseen by CMS. Because if the dental office actually wants to do this, for God's sakes, read it and weep and go for it. But I don't think, I can go either way on this one, but it's not just related to agencies or not just related to entities which are overseen by a specific agency. It's our whole system. And we have a fragmented system, and so be it. But we need to homogenize what we can.
Is there a way to include both, kind of like what we did with the FDA and then
We can,
including, yeah, and say, all CMS, entities and other offices, outside of CMS
and-
that use tissues such as dental.
wound clinics,
Yeah,
et
like
cetera,
be
et cetera.
very, very specific, because that calls them out, right? They can't get away from it, right? That encompasses everything.
I was thinking that we might get questioned about what do you mean by critical data elements? Should we have an example there? And we can take the example from what's below there. Accommodate a variety of long, distinct identification codes assigned to products. That would be one example of a critical data element. I know I might be liking these parenthetical phrases too much, but I think it answers questions we would get.
Rita, are you concerned, Diana, in a sec, but Sridhar, are you concerned that if we don't name an entity, that no entity will do it?
Yes.
Yeah, thank you for the direct response. We agree.
We have been talking about this for 20 years,
Yeah.
right?
Yeah.
And I think Sridhar brings up an excellent point, is we need to say this is the group within HHS which does do this, and please do it.
Otherwise, it's not really any different from
Right.
they were all open-ended and nobody did anything, right?
I agree, Sridhar. You're spot on, right?
So what, Diane, and then what language should we include?
Okay, I was just gonna offer that when you're talking about the critical element, one of the things we often do in regs is we'll say including but not limited to. So if there are certain critical elements, and then what we would do is through our, if we can't promise anything, of course, but if we do ask, determine if there are other elements that including but not limited to.
Yeah, and the work group had identified the long distinct identification code as a problem. Even ISBT 128 would not fit in these software systems. So that was a learning experience right there. It was like, wow,
But
that doesn't
Epic
fit.
said Epic takes ISBT 128, it takes GS1, it takes a whole series of different coding systems, and
Yeah.
it can use, they were very specific about that.
Maybe the other software company.
I don't know if
Yep.
the other ones have modified. I'm pretty sure Epic said they could.
Epic
Now-
does.
Yeah, but you have to have a scanner that can do that. So that's not Epic. You have to be able to program it as the hospital. Like there are other steps besides having the field capable. But even the the universal device code, I know Epic can take that, and that's a pretty long code too.
We are 40 minutes away from wrapping. So how are we feeling about this one? Add entities. Add CMS to this.
So the next one's gonna overlap a little, but that we should probably go to that one.
Yeah, let's.
Okay.
So, and then to improve quality, equity, and outcomes related to related to tissue biovigilance, federal agency with oversight of healthcare coverage should promulgate regulations that require healthcare facilities to use electronic documentation to track tissue products, ensure all critical elements are documented, and require investigation of adverse events related to tissue recipient. And then the rewrite is here. Did to. Large part of this goes into what a biovigilance package is going to look like. If it's in the in the EMR, as to say, what elements do we want to know? And I don't know if it's the job of this committee to do the specifics on that, but it certainly would be to formulate a way to address what's knowable and what's not knowable, and to come up with a package to deal with it, and whether you'd want to recommend an approach dealing with it. But I would certainly state at the beginning that we have to address the issue that we currently had, which is risk, which we'll get to, I think, in the next section, as to what are absolutely essential elements which need to be available for biovigilance radiation.
Could we temporarily click down so that we could see all the comments from CMS on one page?
Diane, where it says a should, and then it's followed by should be required. The should, could it be a must instead? And it's in the CSG groups, that 2A comment or rewrite. Should promulgate regulation and guidance that require. So is it okay if that says must?
Yeah, I think in the uniform donor history questionnaire, we've gone away from compound questions. And so suggestion was require electronic tracking, but then it also is saying require adverse event reporting, and then it's getting specific to adverse event reporting of infectious disease. I would separate electronic tracking of tissues, adverse event reporting. And they're both important, but
Don't link them. Don't link them. They're separate activities.
Plus, right now, that was what I was going to comment on. It says it requires adverse event investigations, which is good, but it actually doesn't say anything about requiring reporting. And if you don't report it to anybody, it's hard to act upon that information. It's not biovigilance then.
Investigation and reporting is in the second part that I think we want to separate.
Those are separate activities, and I think the electronic medical record or the electronic systems can certainly facilitate reporting in an easy fashion if they build appropriate packages. Work group, there's going to be a lot of discussion.
Is there a sound issue?
Sorry, we were just muttering.
Okay.
Yeah. We're running out of time is what we're doing. So we need to get these in a votable form.
Yeah, should we be focusing on the comment from CMS?
I think that's the one we should be using as the fundamental.
Yeah, I think we could, put strike throughs on the original.
Okay, so why don't you get rid of the first thing that we have up? Yeah, just get rid of that. Delete the first sentence that comes from CMS. We're going to accept all of that. Nope, leave their things intact. End with the colon to read. So get rid of that first sentence. And then so to improve quality, equity, and outcomes related to tissue biovigilance, state and federal agencies, with oversight of relevant facilities. And then they mention all of them and tissue source entities, and they mention those. I think we, in keeping with what we've said before, must promulgate regulations and guidance rather than should. That require these entities to document and track tissue products to ensure that such products can be tracked to specific end users and tissue recipients as applicable to require investigation and reporting of adverse events. Yeah, and that would be the second one. Yep.
I
As
think we
applicable,
want to
period.
enable the investigation and report. So it's not just tracking to the recipients.
Yeah.
It's to enable the report back. So we may want to leave. Not talking about the actual.
Yes, I think we want a full stop at it after as applicable.
Yeah, put a period there at the end of that.
and then another, separate it to a new recommendation entirely, yeah. Then just, I think we just repeat, state and federal agencies with oversight of relevant healthcare facilities. You don't have to use the parenthetical examples again, you don't have to do that. Must require. And then wordsmith after that. Yeah, must require. There you go. What was the comment that was made just a minute ago before we separated them? To enable.
I think you can remove the federal after relevant and.
I don't know where enable would go.
Yeah, I don't think you need to say enable here. If you're requiring them to do it, they'll.
Oh, okay.
enable.
Out of the proposed recommendation from CBIS.
Yeah, all that below CSG can be deleted. Maybe deleted. Could you remove track changes or, yeah, remove track changes so we could just read the clean document? Thank you. A question about the end of 1A. The manufacturer's request for product disposition should be required. That I'm interpreting to mean that manufacturers must require information about final disposition, and we don't do that with blood. I mean, the blood supplier doesn't ask for the final disposition, so the transfusing facility maintains that. So, is this?
I
They
think it's
only,
because it's part of their way of tracking.
but they only need it in the case of an investigation. Right? That I don't think every tissue bank really wants final disposition of every.
Well, they want, if it goes into a person, they definitely want final disposition of it, but I don't know if they want, if it expires. I don't know how that, I don't think that they want final understanding of what happened to it. I mean, we can ask for it, but
I think that
We ask for it.
You
to
do.
complete the record.
So
Yeah,
for even when it's not gone into a patient.
absolutely.
Yeah, I
Because
think I think that it's useful if hospitals document it or healthcare providers document it, and
We definitely document
Well,
where
I
it
think that-
goes. If it's in the blood bank, we do.
I think
And
it's
if
useful also the tissue establishments have that too. I mean, that's
And I think if this creates policy change, this actually could benefit the blood industry. I always say for my birthday, I wish I had access to the EHR of the final disposition, the indication of the patient, why they were transfused, having that information. I think the area that this is going to be challenging, unfortunately bring this up, is cybersecurity. So that is why I think it's going to be hard to actually have that integrative information pass from one to the other, is figuring out a way to protect PHI and making sure that people feel safe that that information can be passed from one to another. But I do think that that could add tremendous value, not only for tissue safety, but blood safety, if we could have both relay of information.
I mean, it makes it faster in an outbreak. If you have 100 recipients and the tissue establishment knows which ones were discarded, for example, then it makes it easier to find the recipients and notify them.
But again, all those implant cards are, a lot of them are handwritten. They're not electronic. And
Yeah.
so that creates the barrier to get it back to them, especially if you haven't implanted it, the drive to tell you that it was discarded in some way or something. It's just harder. But if you could make it where it's barcoded and you could, have that communicate, that's why it's so important for it's really an electronic system, not just the EHR. It has to be both.
Jim Bowman has been texting me, and I think that you should all sort of consider this as another option. Basically, all tissue products cross state lines, and maybe there's a federal agency that can cite the interstate commerce statute and or regulation that would provide authority for the secretary to enact national federal regulations to track tissue products to the end user. Universal tissue donor ID that even local clinics and dentists must comply with, and maybe Diane may have some comments.
Oh, Megan, please.
Thanks. Related to this, when I'm reading this, I mean, I generally agree with it. I just want to bring up something that I just hope that if it becomes a sort of a standard that goes to the hospital, my worry is that the hospital would meet this by suggesting that the tissue banks and blood banks sometimes are under the same leadership as many of these amazing members here. But in some hospitals like mine, they're under different leadership. And so I've had times where the cell therapy or tissue wants to use my blood bank module, and it makes me very nervous to have people that don't report under my CLIA to be using such an important system and process. And so I just want to, I don't know where it goes in here, but I don't think we should support this being met by taking a blood bank module and using it for this purpose. And because of the intermingling, because of the concerns of oversight, and that you'd have different types of staff doing that together. It really is kind of a nuance in the weeds, but I do think that if you just put this on the hospitals, they're going to go, well, I'm not going to go buy another module. So I'm going to use the same module, and I'm just going to combine these things. And it might work in some places, but it doesn't work in others.
Yeah, it's definitely not what I recommend, but it's what we sort of did in the beginning, was adapt the LIS system because it was centralized. But we had still a lot of compliance issues, right? Because we weren't in charge of the implantation part, because that was happening in the ORs. So we had to work very hard with this, with surgery to be able to talk about disposition, getting information back, all of that, because it becomes under the responsibility of the blood bank. So I think that if you adapted that and you were not in charge, like we ordered it, we vendor qualified, we did everything like we treated it like it was blood. But if you can't do that and you don't have control over that, then I would highly not recommend adapting your system. Nor do I think now there's too many different products to really make one of our blood bank systems work like a tissue bank system. So I think,
yeah.
go
I mean, I
ahead.
agree. I just feel like forcing a hospital to buy more software is a challenge. And they're gonna look at the market and they're gonna say, well, we already have a blood bank system. And I also worry about the staff in there. If the staff that don't report to the blood bank transfusion service are touching tissue in that system, they could potentially touch a blood product, right? So intermingling is a risk, and it's just something I wanted to bring up. And a hospital's not gonna go buy extra. It's hard if you're forcing a hospital to do something, and then they're gonna figure out what is the most effective financial way to do that.
Well, I think what we should say in here is that we should use a uniquely adapted system that is for tissue. We should call out that we want the electronic part to be tissue specific, not adapt another system that's not really made for that and do it that way. I mean, look, we get asked to do donor milk. You get asked to do a lot of things in the children's hospital, but we're not going to do that in the blood bank just because we have good trackability and traceability. I think it's a similar thing here. We should just maybe call it out so it doesn't get, a hospital can't do that. Let's put it that way. But we could be more specific.
I don't think we should be more specific. I think we leave it to the hospitals if they want to figure out how to solve this problem. I've lived these problems that they're talking about and I know all about them, but this is not for this committee to solve.
Yeah, Paul, I guess I just have to say I disagree. I know that at many hospitals, it's under the same leadership and a lot of those people are here. But in other hospitals, it is not. And it is really concerning. I have been asked this question to put things in the blood bank module and really struggled because these people that do not report to me are in my blood bank computer system. So I know we're talking regulations, but I'm just saying it's a risk.
So in 1A, you couldn't say the use of tissue specific electronic systems must be required?
I don't know, because I think if it's under one leadership structure, then it might be okay. So it's like getting into how does the hospital structure itself, which I realize is feels outside of the scope of this kind of standard. I just don't know if there's, as we talked about in the last section, there's not really great systems to do this or expensive, unique ones that nobody wants to buy or that maybe many hospitals don't want to buy.
Well, the Joint Commission, I believe, talked about centralized versus decentralized systems and that it's okay to have one or the other. So they've sort of left it up to the hospitals at that level. So I'm not sure that this really fits into that. It is really up to the hospital to decide which way, or they can have a hybrid way that the blood bank does some of it and the OR does some of it. But I hear you, but it definitely is a hospital driven thing, not necessarily from here.
Glenn,
Just a quick sentence structure question in 1A. Electronic, now it's moving. Electronic health records must have functionality to accommodate one, a variety of long distinct identification codes assigned to products, and two, manufacturer's requests for product disposition information from end users, including human tissue that was not implanted, period.
There are two issues that are sort of waving around. One is what Marilyn Levy brought up about interstate licensing. Is this something, I'm not sure we have time to touch that. Today, we have just like 20 minutes left. So I think it's an interesting point, an important point, but I don't think we're clearly going to have to meet again to deal with working group 4, which has incredibly important recommendations that should be considered. If the group feels that it should be taken up, I wish Marilyn were back in the room, then we can consider doing that. The other is this operational issue that Megan brings up that has validity, but ACBTSA tends to make recommendations of what to do, not how to do it. So I personally am on the side of just leaving it out and letting the hospitals deal with it, but that's just my opinion. Other people want to insert language that will address that? Bueno. Anything else for this recommendation? For these 3 recommendations? Okay, shall we vote? All those in favor, and online, please, use reactions or go on screen and show raised hand. Lou, I haven't even said for what yet, or are you raising your hand? For recommendation number 1 with 1A included, all those in favor, please raise your hand. Any opposed? Passes unanimously. Recommendation number 2, for all those in favor as written. Any opposed? All right, number 3. All those in favor as written. All those opposed? All right. Well done. We're supposed to be here for another 25 minutes. Thank you. Do you want to just wade into working group 4 so that we have a sense of things, or give everyone a little more time? People want to just, let's keep it going. Okay.
So working group 4 was about adverse events and reactions. And in this group, we had people from the implanting side, orthopedic surgeon, and others, as well as the hospital and the way that events are identified and recognized. We did some discussion about the recognition through highly unusual events, which are the usual things that come through departments of health and through the CDC. But recognizing that there are lots of infectious events that occur after general surgery, with a wound infection rate typically of 1%, plus or minus a little bit for clean surgery. And the question of how much was related to tissue products which were implanted versus not it's a total mystery, and it's just not in the literature. So we'll recognize that and say that this is a little bit of a goof. But we do know that because of the implantation of tissue that was associated with infection, that there is risk. And so the first one that we wanted to do was to improve communication from healthcare professionals to inform a patient who may receive a tissue product that there is a potential for risk of disease transmission, such as descriptions regarding higher risks attributed to products that contain live cells. National guidelines should be developed and processes, and to describe such risks in professional societies should be encouraged to promote those guidelines. Now, the orthopedic societies and the plastic surgeons, and they already have things that say you should do this. So the question is, as a surgeon who does this, the question is, how do I give informed consent? And as Lou pointed out yesterday, that a lot of the tissues that we have minimal risk and a bunch of them have more significant risk. And so the question is going to be of risk identification. You know, if you go and buy a pack of cigarettes, it has a big black box warning that says, this is bad for you. Don't do this. And a lot of other things labeling wise have warning associated with the products that we don't have on tissue. And so the question is about both what patients need to know and what the people giving informed consent need to have available to them to discuss this is one of the issues that we need to talk about, both in terms of what is adequate informed consent mean on one side. Like has been said, we don't have a lot of numerator and denominator to say what the actual risk is. We have some stuff from the organ world, which is probably an over concern. We also know a lot of the false positives which come up on the organ side, which go through. And we also know that most of the reports that come into the DTAC are not about the end users who've gotten it and are concerned of it. A lot of it comes in through the OPOs on the front end about risk assessment. And so how to get the right numerator and denominator is really unclear. And I don't think we should make recommendations about that, except it'd be really nice to know, but nice to know isn't what the ACBTSA do. But we do need to say we have a problem that we recognize, that unprocessed tissue has caused a lot of problem and has killed people, that we should put black box warnings on different products. That goes for both the person giving the consent and the person who's receiving the product to say, yeah, I recognize the benefit may outweigh the risk, but I have a say in this as to whether or not it should be done. And it's not something we do today. I mean, we do it in organs and we in theory do it in blood, but when I see people sign the consents for blood, I don't think we do as good of a job getting informed consent as we probably should. But it is part of our regulatory component. Some of us do it a whole lot better in organs than others, but it's a very important concept in principle that we recognize the importance of the recipient of these products accepting the risk associated with it. So that's where that came from. Let's go through all of them, then we could go. And then the second one is federal and state regulations should publish guidelines to assist end users, physicians, hospitals, and physicians who treat tissue recipients on how to properly identify a reaction that is attributed to a tissue product. These regulators should require end users to report these things to an adverse reactions and cooperate with investigations. A lot of this is Scott's frustration with the fact that we don't answer. And a large part of it is related to the fact that the people who put in the tissue don't follow the patients afterwards. It is the way our healthcare has evolved. A lot of the surgeons who implant tissue typically don't see the patients afterwards, except maybe once or twice. Most of the complications associated with implantation of tissue are being seen by nurse practitioners or extended providers going through, sometimes people who cross cover. It is just part of our system, and the lack of continuity in implantation versus management of perioperative failure to heal, infection, complication, all those things are multiple, and inside of all those complications is potential disease transmission. And the high turnover in healthcare today is going to be almost impossible to get people to know how to deal with it. But this is an intent, is to say, somewhere in all this mess, we need to figure out how to make sure that people recognize that these are there, that human tissue is associated with a given risk of this, and that somebody should think of it somewhere along the line when it comes to an adverse event. And how those are defined, whether they stay completely in the professional world, whether there's a regulatory component on top of it, just to describe, but we do it poorly today. It's recognized that it's a gap, and we need to somehow address and close the gap. The comments from CMS, CSQ, and the clinical standard group changed a little bit. Federal and state governments should publish regulations and guidance that require consignees and end users to educate physicians, dentists, and other applicable healthcare practitioners who treat tissue recipients on how to properly identify and report an adverse reaction that may be attributed to a tissue product, and the duty to report and cooperate with any subsequent investigation. Personally, didn't know how to report something. I know how to do it to OPTN, but I don't know how to report it to.
I was just, one of the things that I used to do is I was work very close with infection control, because even though the surgeon who put the tissue in may not be the one who's eventually, but when people are recouping in the hospital, at least, and if there is a wound infection or somebody comes back into the hospital, like they've left and they come back, that they would cross with us to see if there was ever tissue implanted in the patient. And I think that's a way that hospitals can communicate. I know we do it for other kinds of things. If, like, for instance, with ortho, that you put in, some kind of metal or something. I mean, I'm just thinking about ways that we can use the systems that exist to sort of have a redundancy, but also they have a purpose that they're already mandated to do certain things, that we could use them in any hospital setting to sort of work on
A
that.
lot of it is that these are going to be recognized as outpatient settings, and they, in the hospital, particularly infection control, won't necessarily know about things which are observed in an outpatient get managed in an outpatient. One of the things which is interesting, I was in Scott and we were going to actually ask at the Notify meeting, is that the EU just made a proclamation and change of their tissue related stuff that said that I can't remember what the interval was. At 60 days, everybody who got human tissue had to report the outcome, both in terms of benefit as well as adverse events and complications. Now, how they're going to do this, I have no clue. And so what I think would be useful for us is to talk to Deidre next week and say, how are you guys planning on doing this? Because this is something we don't see a simple solution towards. And what kind of regulatory mechanism is going to be used inside of tissue implantation to get a 60-day compliance with reporting of outcomes? And because most of it is done there too, is outpatient. I don't know how they're going to do it, but they have done the mandatory reporting of both not only adverse events, but beneficial events as well. Don't have anyway.
For number 2, the comments from the 2 different groups. How do people feel about the inserted language?
The AAS is the orthopedic surgeon group. Already does highly recommend to their members that they obtain informed consent and that they play ball with everybody. They just finds it difficult to get continuity, leading the circle.
And it's the tissue establishments too. They ask the same thing we do, and they're not getting it. And they report that to us so that we try to get it, and then we still don't get it.
So on these, you kind of singled it to physicians and hospitals, but are you doing that because that's where you think we can get the most bang for your buck, and you don't want to get to dental offices and all of the others that were listed in our revised number 3?
Well, actually, the CSG from CMS, they provide. They actually say physicians, dentists, and other applicable healthcare practitioners. So it may be a good idea to start with A2A and work from that one.
Again, we were not wanting to overstep what we thought that the committee could make a recommendation for government is to stay within the perfection is an enemy of good.
We were discussing in a sidebar yesterday that state governments, we haven't included them in all of this yet in the discussions. So that would be a step that the advisory committee or someone would have to make, to communicate with them that, this is, well, when they're finalized, the recommendations that they're included in this. And then that's where the work group said that some oversight of dentists' offices fall under state governments. They weren't specific about that, but that's something that we need to understand better.
Yeah, so, for recommendation 1 here, essentially, it seems like there should be the development of at least some sort of template for informed consent. So some federal entity should take.
I think if what I would want us to do with 1 is talk about informed consent is critical, particularly for tissue which just washed off and frozen, or washed off and used right away, or something like that. So ocular tissue and certainly the demineralized bone matrix, which gave the TB. Valves and stuff. I mean, there's a whole series of things which we don't subject them to any kind of serious processing, particularly irradiation, which seems to work the best. Just antibiotics, soaking in antibiotics. I mean, that was the pericardial patch that transmitted hepatitis C. The radiated tissue seems to be pretty safe to do. It's not going to be 100%. It's not, the processing issues can't contaminate. There's all sorts of things that can happen, but the risk association that has been seen with the mycoplasma, with the TB, with a variety of things, they are associated with things which are not irradiated. And it's minimally processed like wash off and freeze, that ends up it may kill all the cells, but it does not kill the bacteria. That's the way we preserve these guys, is to do that. So that the things which do not bioreduce burden need to be highlighted and on the label, and that so that we can actually give decent informed consent. So those are the 2 parts, I think, which are here. People need to know the risk, and we need some sort of stratification for risk assessment, and a labeling component which states that this product was minimally treated in terms of bioburden reduction, and that needs to be on a label that can be said. It's already done for blood. I mean, this is not all that exotic. And blood they tell you what the anticoagulant is, whether you need to wash off stuff, if it's got glycerol in it. They tell you all sorts of things, which is incorporated into the labeling system, which can be incorporated into a labeling system on human tissue, which is different than device labeling. I mean, the majority of device labeling is processing related issues, as to making sure that the chain of custody or is kept intact. And we need to go ahead.
Ray, but first I'd like to say we're pretty much at time. Now, if I want to be considerate of people's time, I know we've been working hard. If you need to leave, that's okay, and we'll end it. If you can stay, we might avert a virtual meeting. So, risks and benefits. Can people hold out for another? I mean, this seems to be an easier one. Can people hold out for another half hour in terms of their transportation, in terms of their mental energy? Okay, let's keep going then.
I'm not sure if this is the place to provide but to maybe take a process that already exists within the blood world. When we provide incompatible products in the pre-hospital setting, we put a wristband on a patient. So I was wondering if we could do a black label wristband that's associated with the product, and would that cover all of your asks, Dr. Pruitt, which is, that we performed a proper consent, and that black label matches the labeling that exists on the minimally treated product. And, because Sridhar was saying, we need to develop a template, but maybe it's more of a system. So it's an informed consent, but also a process that shows that that patient has fully engaged in a consent and now has a visible label that they wear. And at 60 days, that label comes off after they've gone through their post process.
Ray,
Yeah, I agree with everything that was said regarding the need to potentially put like a black label warning, some type of indication on the products that list. Whether people follow those or not, it's up to them. Just like the pack of cigarettes analogy. But that's not what this says. What this says is that some unnamed organization is going to get together and decide what to do. So is it that we want to be prescriptive in saying that, some type of a warning label needs to be constructed to be affixed to certain products? Should we name the specific agency that's going to be involved in creating what that is or defining what that is? And make it a requirement to do that? Because I think as the recommendation stands, yes, I agree this should be done, but it's not doing what I think we're saying should be done. Is to have that and who is going to do it.
So, a few years ago when we were looking at organ transplantation guidelines for HIV, hepatitis B, and hepatitis C risk, several years ago, there was a requirement that there was separate specific informed consent organs from increased risk donors. Then when these were revised, we recommend, I guess we wrote what we felt were sort of a template of how the informed consent guidelines should be modified. That rather than a separate specific informed consent, the organs accepted, the risk factors, and the donor are different. And I think when I look at this, there should be something similar to that, right? There should be some federal agency that takes the lead in working with other agencies and stakeholders, develops templates for informed consent discussions so that providers can understand what sort of products they're about to implant in somebody, and then have a discussion with those patients regarding the level of processing and what.
Yeah.
Or to write it like that.
Would that be FDA?
I think it's something we could do. Yeah, we could create a template. We wouldn't write the informed consent document.
Risk,
Create a template.
it's a risk identification.
Right.
That just needs to be available. Certainly the people who are going to receive it, like the poor guys who got TB when they had the stuff put in their mouth or in their spine, but also for the people who are giving informed consent. Both those groups need sufficient information to say, what's your risk? I mean, because it's certainly different with irradiated ground up bone than it is for product that just comes straight out of frozen. It's a very different risk profile.
I guess,
Absolutely, and those products won't look that very different to the end user. They just
And they
have a
won't
vial
look
of
different on
something.
the outside. Right. They look very similar in a package.
does that go back though to another fundamental question, which is sort of a level up to say, if that risk is so significantly different, why are they not regulated differently? I mean, do you need a separate category to say, in the example here of what we're saying, living cells? If there's a material, they're not irradiating it because they want living cells in it. But that is carrying additional risk than having the ground up irradiated material.
Well, we don't know what the risk. That's our problem. It's
right.
a very low number, but we
It's
don't
a
know
very,
what it is.
yeah, we don't know the number, and historically it's been a very low number. And so having two events back to back has forced us to reevaluate the donor screening and eligibility determination. And the wheels are turning partly through this advisory committee and through the professional societies to make changes to mitigate the risk going forward. But to Tim's point, even at that point, after all those changes are put in place, we still have to do more work to determine what the actual numerical risk might look like for these products. But I'd please ask this committee to historically take a look at the risk profile for these viable cellular allografts has been very low with very limited impact on patient safety up to these last two cases that were devastating, obviously, for those patients. Just please keep that in mind if you can balance that.
I think we just need to recognize that this is the state we're in today. We don't know a numerator or denominator, whether it goes from 0.001% to 0.1%. You know, when I talk to my patients, you know, the difference between 97 and 98% survival or something it's the same for them, even though statistically it ends up being a 0.001 kind of thing. We just don't know. And so it goes into the thing that Sridhar just said, is to say what's high risk and low risk. Well, having a disease is really bad, and high risk, that we had almost no transmissions of HIV, Hep B, or Hep C with our given system. We did have some, but it was certainly a lower risk to get one of those than it was to have your disease and go ahead and die. All depends on what your comparator is, and we don't know where these comparators are and and this is where but we do need to make sure that the people understand who get these products that they're have the potential for getting something they don't want. And whether it's TB, whether it's mycoplasma, it doesn't matter what it is. They don't want it. All they want is their back to feel better. And getting something you don't want and dying from it, which is God forbid, but even if you don't die, I mean, it's still not what you wanted. And that's what we need to give. We need to provide sufficient informed consent. And we need to provide information to the people obtaining informed consent that they can actually give appropriate risk benefit ratio. Some people are going to say, no, I don't want that stuff. That's appropriate. But that is, I think, the fundamental component. And then the other issues then are how do we use the guidelines and assist? I mean, without real numbers, it's hard to deal with this. And, you know, when I look in the existing literature, this is you guys, is how to separate out conventional surgical site infections, which are caused by just anybody operating in a clean surgical site versus what was a transmissible disease. There's nothing in the literature to say that this is the contribution of tissue, human tissue, versus this is just life that happens after you have an operation. And how to separate that out, how to give appropriate guidance, how to do it, I don't know how to do that. I honestly don't. Yeah, I think a 60-day follow-up, which is what they're proposing in Europe, is not a bad start. But we'll have to see what if it's even feasible. I mean, ooh.
Was the intent of that addition in one to say donor-specific risks or tissue-specific? Or was it about viable products that contain viable live cells? I think it was about products that contain.
Yeah, this was about live cells. I mean, I think the idea of doing risk stratification, depending on very useful thing that should be on.
One thing to note, if Europe is successful with implementing a 60-day follow-up program, there will be US tissue banks that currently supply to Europe that will have data based on their tissue and their manufacturing processes coming back to them. That could help us at some point.
I would stick to live cells just to reflect what was earlier, yeah.
Other comments on number 1? Sandra?
You want to make sure that you put assent and consent in here because for kids, especially for orthopedic stuff and things, so just make sure we add that piece.
Pediatric group needs to be included in the full informed consent, the differential with parental consent and their assent of products.
For the wording on develop templates, do we want to change it to maybe something like develop informational materials? So it's not, it could be in the form of a fact sheet or not specifically say templates.
Sure. Thank you, Suchi. Sandra?
I don't know the answer to this. Maybe y'all do about nerves. Are nerves in the realm of more fresh tissue? They're not treated at all? Like
Would you ask about nerves?
nerves? Like, are they
nerve.
like live cell, like a peripheral nerve, you know, kind of implantation? Is that more of an untreated? Because it's just not in a lot of things we think about, but there was a lot of hand surgery that was done over at the Children's Hospital. And I can't remember if that's a treated product, but it might be something we call out because people don't think about it all the time.
I think for the most part, they're non-treated.
They're not treated.
But
Well,
it's not my sweet spot.
Mm-hmm.
I think they could.
I was just thinking about naming off some of the tissues that really belong in the category, like the cardiac, the
I think
nerve.
it's about the processing as to what
Yeah.
processing
Yeah.
components were there, because the
Preser-
fresh bone.
Yeah, preservation method.
Yeah.
Okay.
And having information about what's done to the human tissue, I think is fundamental. I mean, that's what happened with the blood work, is that you guys know what has happened from the time it left the vein to the time it gets put in a bag and then retransfused into something. You know what's in there, whether it's an anticoagulant, whether it's preservative, whether you've done leukapheresis, whether you've done any of the different things which go through. It's available information inside of the coding system. And so having relevant information for both user and recipient, I think is important on the in how it's labeled.
Anything else? Number 1.
Hi, may I make a suggestion?
Please, Sarah.
This is Elisa Gordon speaking. Because it's important to ensure that the informed consent process is patient-centered, I'd like to recommend language that would involve finding out what's important for the end user. What kind of information would they need in order to inform the informational materials, for example, as opposed to assuming that, you know, we all know what belongs in there.
Maybe that would go into that number 1 at the end, the last sentence. Society should maybe research and develop informational materials.
And if that's a really good suggestion, if we could incorporate somewhere the idea of it being patient-centered or end-user-centered so that we know we're addressing their particular information needs to make an informed decision. Thank you.
So we turn our attention to number 2 and decide which version.
I mean, I think we should use the first one. The second one is not.
You mean the CMS
Yeah,
version
the
or
CMS version. I think the CMS version, not the AAOS version.
then let's please delete the the initial version. Yeah, thank you. And delete B as well. Okay, so that one's gonna have some grammar issues. I've been waiting to see what happened before I said anything. Because right now it says it requires the consignees and the end users to educate physicians and dentists, and I'm not really sure what that means.
Should be healthcare facilities, right? Should educate physicians.
Our healthcare facilities.
Whatever language they use.
Oh. Yeah. Does it matter who gives the education? I'm seriously just a question. I mean, if we require that the education happens, maybe CME providers do this, maybe medical societies do this, maybe, you know, the hospitals do this, but I mean, does it matter who develops it? It's a question.
It was who develops it. It's more that they're actually. Go ahead.
Well, here, we were concerned that, for instance, we've gotten feedback that, it's not a specific training, but that surgeons get it if it comes up, which you would think it would come up during the years of residency, but just in case, they might not have experienced everything or got a full education. So if we require that they receive education, at least all the different parts, identification, who to report to, that type of thing, would be covered.
100% agree with you. I guess what I'm saying is what you just said was you said they should receive education, but I guess it's it's one thing to require that they receive education, but it's saying that who has to provide it right now. And that's the part I'm questioning, whether that's necessary or whether we should be more broad, and it's just a question to ask, not.
Well, I think that's a good point. We think it's important that somebody provides the education to the healthcare, not just the surgeon, but the other healthcare personnel that are dealing with this tissue. So as to where it comes from and that, I think we'd have to, I'm not sure if we know enough to know who should do that at this point.
And that's kind of my concern too, because I feel like if we require the education, then we got to figure out who gives it, which is fine.
Right.
But that at least gives us time to figure out who gives that, because I think there are multiple different possible sources of that education. And that if you're saying it, we only require that the hospital provides that education, it's like, well, a lot of times we say you have to be educated in order to get your license to prescribe drugs, right? And so there's a requirement out there, and then there are multiple different ways that that's being fulfilled.
Well, I guess that's what we were getting at. We want to require the education, and there are I understand there are professional societies that have education, different groups may provide education. So we wouldn't be telling them exactly where to get it, but that they should choose some avenue in which they can get this education and provide it.
Agree with that.
Get rid of that part and go publish regulations and guidance that we require the education of physicians, dentists. I mean, I don't know, but I think that's the essence of what you're trying to.
I think so.
Yeah.
Yeah. I would just add that, I mean, it's the hospital, the COGS and the ASCs that we can regulate. So we can't regulate other groups in that. So if CMS chose to do something along these lines, it would, our authority would only go so far.
Is it negating? I don't want to negate what you were trying to say. Does this negate what you were trying to convey by
No,
not?
I
Okay,
don't
ju-
think so, as long as you say, someone has to provide
Okay,
it.
okay. I just
Yeah.
want to make sure we weren't crossing
Just
it out.
wanted to make sure you understood that, we can only regulate those entities we have authority to.
Oh,
Other
absolutely.
people-
And all these people are practicing medicine under this authority, under the
Right.
hospital.
And
I just-
by leaving it more general, then, it could be provided by other people. We
Great.
just could not personally regulate it.
In number 1, can we change the shoulds to must? Yeah? Yeah? Okay.
I'm wondering if we should also define, as we did in the past, what these groups are. I'm just envisioning that are going to carry these things out, or that we're expecting we're going to carry out. What happens if we come back in 5 years and none of these things are acted on, and everyone sits around the table and says, who was supposed to do?
Yeah,
If you don't designate someone to do it, how do we follow up?
First, did we get all the shoulds? Should be encouraged, must be encouraged. You must. Yeah, you got it. And then you're suggesting, Ray, that we name the people who are going to be doing this. Yes, the organization.
How did we handle that earlier when it was federal and state governments? We didn't put who have oversight of healthcare facilities. We didn't say it that way. I was just, if we can scroll up and see.
So is this where you want to use like Joint Commission and everybody that we know? Like all the agencies that are there, just list them out? Is that what the kind of thought process?
Yeah, see, there it is. It says state and federal agencies with oversight of relevant healthcare facilities. That's what I was thinking we would put here.
But that still makes it, well,
There's only a few that have that oversight.
we can put, you know who you are.
Like use a comment bubble.
That'll work.
I don't know, maybe we should be specific. Like I know the state ones know who they are, but the federal agencies seem to be, there are a lot of different or accrediting, I don't know. I mean, I don't know if we.
CMS waits for the state to do it.
I would defer to CMS.
Well said.
It's like a ball.
I'm certainly not going to tell you to put CMS
Yeah.
in there. But, I think it's just, there's overlap. As we've been discussing, there's clearly overlap. FDA goes so far, then CMS regulates certain people. So with the overlap, I could see where, that's hard to say exactly. And, the issue of who goes first, I'm not going to touch that one either.
Well, can I ask a question? Who is in charge, or who is, under what regulatory body is informed consent for organs or for blood? How does that read when we have informed consent for those things?
We have certain requirements in the transplant hospital regs on informed consent. Someone else would have to speak to blood.
Yeah, this sounds like requiring continuing education for opioid administration. There's a lot of things physicians get asked to, they're required to take continuing education for this and that and the other thing. This sounds like that, like for opioids, if you want to raise it to that level. So continuing education is an option here.
Would that same language apply under number 1? Federal agencies.
Take out the with oversight. It would just be federal agencies and parentheses. CDC has no oversight.
Would CMS have involvement with this though? I thought they would. With developing,
Well,
yeah.
we could take out with oversight
What if we put
in number
CDC
1 and
what
put
if you put
CDC in
CDC
parentheses.
first? No, and keep that, if you keep that and put CDC first. CDC and federal agencies, yeah.
Okay.
There you go.
I think maybe the other federal agencies, because they do not have, CDC does not have oversight of them, if I'm correct.
Right, that's why I thought we could
oversight
keep
is
you could keep oversight there, the language, because now you put CDC first. And federal
with-
agencies, not take away other, because
That's what I was trying to say,
Yeah.
take away the other, that's it.
Yes, Michelle.
Is end user interchangeable with hospital? So in number 1, you refer to informed consent for patient in line 1, professionals to inform a patient, and then somebody made the comment to ensure that we stay patient-centered, but instead of changing it to patient, it was changed to end user centered. Should that be patient-centered? Seems like, are you making information to educate the doctors about risks? But it seems like this is directed toward patients. So can you change that to patients? Yeah.
I think we do
That
need
makes
to educate doctors about the risks. I'm not saying we don't need to
Right,
educate the
but
end
number
users.
2, but this is for, yeah, the goal of number 1 is to improve communication for patient consent, right? Oh, I see. Oh, okay.
That's what.
But it is for the doctor. Okay, okay, okay,
About.
okay,
And then they're.
yeah,
So you were right. About
yeah,
Still.
okay, and then that's with the same with number.
I don't think anyone's mentioned it, but the process of informed consent also gives the patient information that they actually got it. Many patients may not even know that they've gotten these materials. So just to add that to the record, that this would help the patient understand that they actually got this and for future reference.
Well, I think that's a very valid point, and I think that a lot of patients don't realize that there is an option to use, many times it's bone, but that it may or may not be used, and a lot of times they'll go over what's implanted, but it's usually, some kind of metal. And they don't get told, it's like a plus minus, you may or you may not get some bone. So, yeah.
One of the things which is really important in all of this is recognition of what you've got. I don't know, I've shown people here. I have a card that was given to me when I had my tooth implant, but it's only about the screw that's in there. I don't have a card about the tissue that was put in my mouth to deal with it. And to the extent that somebody's going to have about a process of what they've gotten done, they need to know what they've got. And the idea of communicating back to patients that you've received a product that you may or may not know that you've gotten, I think is fundamental. I mean, not everybody knows they got blood, particularly when they go to the OR. Not everybody knows they've gotten a lot of things, which they do get in our routine healthcare system. And I don't think we addressed it here, dealing with this, but the notion of informing people what was done to them, products were given to them, I think sort of part of what we should be doing, which we don't do at all right now. And I think that's a must right now, but it should be an aspirational goal that we do have, is that people know that they got this stuff, and if they're in the venues that they have to say if they're not, what they can do about it, what recourse is if it doesn't meet the needs in their
I just want to make one last comment to that. Now that patients can actually get into the medical record and see all of it in real time, I mean, it may be an opportunity to be able to help with this understanding of what they get, having a tissue tab, having we have a blood tab. I mean, to help patients navigate so they know what it is that happened to them when they were in the operating room or somewhere else. So, thought.
Any other comments about number 1? Going. Okay, how about number 2? Okay, and number 3. Please change should to must. Yep. Are we ready for voting? To go home. Okay. All those who are still online? We're going to go to vote for working group 4, recommendation number 1. All those who agree with it as written, please raise your hand. Okay, anyone against? Okay, we have got unanimous on number 1, unanimous pass. Number 2, all those who agree with it as written, please raise your hand. Anyone against? That is passed. And number 3, all those who agree with it as written, please raise your hand. Any against? All right. Huge thanks to the committee for taking time out of your busy schedules, coming and working so hard on this. Huge thanks to the ACBTSA staff for providing support for us to have this meeting. And the largest thanks go to Tim and Scott for 2 years of hard work that has culminated.
Just a quick thing, this is officially closes the 59th meeting. I did look at the memberships that were voting. We did have a quorum, so the votes are successful. Thank you.
Produced by the U.S. Department of Health and Human Services.